Katie, can you hear me? Katie, can you hear me?
Yes, can you hear me?
Yes. Can you increase your volume a little bit more? Is it?
Let me see if I can. Is that any better? Hello?
Yeah, hello. Yes, that's fine.
Okay.
Good. So this is just, I'm going to introduce you in a couple of minutes. We're going to wait for more people, okay?
Okay.
I'll
And
let
then
you know.
when I do that, this Zoom webinar that's open, there's a share screen thing. That's when I click that.
Exactly. You share the screen, correct. You have to,
Okay.
Yeah, okay.
That makes sense. Thanks. That's fine. Oh, yeah, that's fine. I brought an old one. That's okay. Yeah. So I have mine open behind you, so I just do it in presenter mode and click that when I'm ready.
Exactly. So once you so you share the screen, but I need to allow you to share the screen.
Okay.
Right now, because I'm sharing, I think you will not
Won't be able to. Okay.
Until I'm stop, and then once I say okay, so you will share.
Okay.
Okay.
All right.
So you have to share presentation
with
right?
this, yeah. So mine doesn't show.
Right. So this is just how do you go to the
like I normally just present, and then it's hold up, but then I couldn't find that other window, so it takes me like a second to yeah, so because I wanted to have the speaker notes for some of those studies, but I didn't want to share that. So I put it on my iPad just so I could read it bigger than my phone. Oh, no. No, the only reason I did that was just because I have some speaker notes. So just since I made this a while ago, that way I can prompt myself. But it's a little annoying because I have to make sure I'm advancing this and not. So. Oh, I brought something. Thank you.
Hello, everybody. We're going to wait for a couple of more minutes for some more people to join. I just want to remind you that we're going to have a special guest next Friday. It's going to be from University of Michigan, Dr. Theodore Iwashina. He's going to be presenting us with some data about discharging patients from the ICU and all the ups and downs of doing that overall in this COVID pandemic. So just stay tuned. I expect everybody to be there. It's going to be next Friday, May the 8th at 12 noon. Will be from 12 to 1. We're inviting even people from all the ICUs, the residents from internal medicine. So a lot of the people in the hospital will be present during that webinar. So I just wanted to let you know about that, okay? We'll wait for a couple more minutes before we start. Thanks. Okay, so we're going to start now. It's a pleasure to introduce Katie Garner. She's going to talk to us today about pulmonary alveolar proteinosis. This is a very interesting topic. Not a lot of data out there. A lot of studies done in the past have been retrospective, and we have been involved here also with some part of the studies done about overall whole lung lavage that Katie will talk to you about. After that, we'll have Hala doing a journal club, which also in referral to this to the same topic. So, Katie, you can go ahead and start sharing your screen.
Okay. Let me see if I can. All right, does that seem to be working? Can you hear me okay?
It is working.
Okay.
So just one more thing, we're gonna try something different today, guys. At the end of Katie's presentation, I'll unmute everybody. So if you have any questions about it, you can speak. Let's try something different that today. You know, it could be sometimes a little uncomfortable just to write the question. But if you feel that you want to write the question in the middle of the presentation, we'll try to our best to answer it. If not, we'll just leave it at the end. But again, everybody will have the capability to talk and ask questions at the end of the talk. Okay, go ahead, Katie. Thank you.
All right, hi everyone, this is Katie. Today I'm going to be speaking about pulmonary alveolar proteinosis. Let's see how I need to do this. Okay, so just to go over what we're going to be discussing, it'll include the pathophysiology and even some of the physiology regarding surfactant in the lungs. We'll talk about the epidemiology of PAP, what to look out for in the clinical presentation of these conditions, and then discuss the treatments. Focusing mostly on whole lung lavage, but a little bit of the GM-CSF therapies, and then rounding out the presentation with talking about the Henry Ford experience here, as Dr. Diaz mentioned. So starting in on the pathophysiology, so pulmonary alveolar proteinosis was first recognized by Rosen and their group in 1958. It deals with the accumulation of amorphous periodic acid shift positive material, lipoproteinaceous, in the distal airways. This is composed of the surfactant, phospholipid, and the apoproteins. And altogether, this leads to hypoxemic respiratory failure. As we'll discuss later on, there is actually little to no lung inflammation involved, and the underlying lung architecture itself is even preserved. So this condition is caused by a significant spectrum of disorders. It involves things that affect the production of surfactant itself. Other conditions are affected because of the clearance of surfactant from the lungs. It's been divided up into three major categories in terms of recognition. The first one being primary, or often also called autoimmune, which involves the disruption of the granulocyte macrophage colony stimulating factor signaling. Anything that is related to macrophage dysfunction really falls under secondary. And there is more of a congenital genetic disorder that affects the surfactant production itself that makes the other category, and that's mostly seen in pediatric populations. So I'm not going to be speaking much about genetics today. So in terms of surfactant physiology, it is a lipoprotein complex that is formed by the type 2 alveolar cells. This contains both a hydrophilic and hydrophobic region. Surfactant works to help lower the surface tension at the interval or the interface between a gas and a liquid. There's also different molecules that work between two liquids or a liquid and a solid. If anyone's ever seen that simple science experiment where you have a bowl of milk with food coloring in it, and then if you add a drop of like dish soap, it causes things to separate by lowering the surface temperature, or tension, I should say. It helps increase the pulmonary compliance, preventing atelectasis at end expiration, and facilitates the recruitment of collapsed airways. GM-CSF is a critical regulator of the surfactant homeostasis, as you can see here. So GM-CSF is produced in those type 2 cells and then attaches to its receptor on the immature macrophages, helping them differentiate into the mature macrophages. So moving on just to describe a little bit more about primary PAP. As I said, this does involve the surfactant clearance pathways mediated by GM-CSF in the alveolar macrophages. It's caused by a disruption in that by the presence of some neutralizing GM-CSF autoantibodies that stop that maturation process. There are also other genetic causes. There's been a lot of different recessive variants of that receptor in different genes. These are the two more common of those rare conditions, although there are several different portions of this that have been studied. And again, I'm not really going to focus on that today, but it ultimately leads to an impaired signaling by the intact GM-CSF molecule. So here's more of another picture following up with the abnormal production. So you can see that the type 2 alveolar cells still do produce the GM-CSF, but the autoantibodies prevent it from binding to its receptor, stopping the maturation of the macrophages, and then they accumulate inside the lung, leading to this PAP process. Moving forward into the secondary PAP conditions, these are mostly disease associated. A lot of them have to do with various hematologic disorders. As you can imagine, a lot of these have different antibodies or different receptor dysfunctions associated with them. There are some conditions that are non-hematologic, but other malignancies that are associated with secondary PAP, and then chronic infections are also involved. The pathophysiology behind each of these mechanisms is poorly studied. The common theme is that these conditions reduce the number or function of alveolar macrophages. Just to continue on with secondary PAP, there's also several case reports and studies that focus on exposure-associated forms, mainly from inorganic dust or organic dust and materials. There are some reports surrounding fumes that are inhaled that lead to this process as well. Again, the underlying exact mechanism is not always completely understood with these. And then just to briefly touch on some epidemiology regarding PAP, it's an extremely rare condition. It has a prevalence anywhere between 3.1 to 6.7 cases per million of people. It's typically, the age of presentation is a little bit later in life, usually at about 40 or 50-year-old. It does affect males a little more frequently than females at a ratio of 2 to 1. And then about 50 to 68% of patients with autoimmune PAP or primary have been found to be current or former smokers. Most of that data comes out of some studies from Japan though as well. Primary PAP does represent 90% of all those rare cases. It typically occurs as a primary acquired disorder of some unknown etiology. There's very few, as I had said, that are related to congenital or genetic mutations. Secondary PAP does represent about 10% of cases, mostly associated with the myelodysplastic disorders. Okay. All right, so the clinical presentation. PAP has a very insidious onset. It's a very indolent course. Most patients are relatively asymptomatic at presentation, or I shouldn't say most, about 30% are asymptomatic. Their diagnosis tends to be made months to years after the initial onset of symptoms due to the time it takes for enough surfactant to accumulate that actually leads to impaired gas exchange. Some patients do have acute respiratory failure from opportunistic infections, pneumothoraces, or right heart failure that leads to the ultimate diagnosis. Symptoms that patients may experience most commonly are dyspnea on exertion or cough. Sometimes they may describe a chunky or gelatinous kind of milky sputum, and then other vague symptoms such as fatigue, weight loss, even low-grade fevers. Physical exam tends to be normal. Sometimes they may have crackles, sometimes there may be some clubbing or cyanosis, but it takes a significant amount of that surfactant accumulation to cause change in that ADA gradient and change the gas exchange to lead to hypoxia. So some of those physical exam findings are pretty lagging behind their symptoms of dyspnea. Laboratory workup, it's really non-specific. You're going to be doing everything to work through your differential of this condition. The only thing that's specific to PAP is really checking for the autoimmune serum anti-GM CSF antibodies. There are some biomarkers that have been evaluated in regards to PAP, but they're not sufficiently sensitive or specific to be useful. So that's why I'm choosing not to mention those here today. But you would be looking for some of your inflammatory markers, making sure there's no vasculitis, going through your differential completely to get to this point. Radiographic presentation. This stands out to me since I clearly remember my time last year as a first-year fellow when I had an x-ray with this condition on it, and I had no idea what whole lung lavage was, so I had read a lot of this information at that time. So just like the x-ray I was reading at that time, they mainly show bilateral symmetric alveolar opacities. They tend to be centrally located. They tend to have that bat-wing appearance, similar to ARDS. A lot of times they affect the mid and lower lung zones, but they can also be very asymmetric, unilateral, nodular. One thing I did come across is that the uncommon features are dense consolidations with air bronchograms. They don't usually have lymphadenopathy, cardiomegaly, or pleural effusions, although that is possible. These images are actually from one of the patients treated here at Henry Ford several years ago. The left image was one of the first chest x-rays I could find back in 2011. As you can see, there's just a little bit of reticulation there fairly centrally. And then following up, I believe this one was from October, and the second one was 2 or 3 months later. There's increasing nodularity in that central lung zone. So there is a pretty significant change there, and I'll have some more images coming up. Just continuing with the radiographic presentation, if you do proceed with a chest CT, they do describe in the 5mm cut images that there are bilateral areas of consolidation, very poorly defined edges, more in a ground glass appearance. The high-res CT does show ground glass opacities, usually in a homogeneous distribution, having more of that central appearance, although it can extend out to the periphery. The buzzword for this is crazy paving with a geographic appearance. Crazy paving is characteristic of this. It's not definitively diagnostic. I'm going to be talking about some of the other things that also show crazy paving in a moment. And that pattern typically is seen with the primary or autoimmune PAP, not so much with secondary. I did find a little bit of information about PFTs when I was reading for this lecture. You might see a reduction in the diffusion capacity that's out of proportion with or without a restrictive ventilatory defect, but sometimes you may not see any change on spirometry or diffusion depending on where the patient is in their course. So that same patient I showed you that chest x-rays on, this is their CT image from 2012, I think the same day as that second chest x-ray. As you can see, it is fairly centrally located. You can see the interlobular septum, you can see some ground glass. It is a little bit more dense, a little bit in the bases compared to, or the lower zones compared to upper here. But this is a pretty classic appearance for that crazy paving. So other causes of crazy paving patterns on high-res CT, this can include anything from ARDS to adenocarcinoma, alveolar hemorrhage, and amiodarone toxicity. Sometimes different bacterial infections can lead to this radiographic picture. Viral infections can lead to this, including SARS. You may see it as a cardiogenic pulmonary edema picture, giving you crazy paving, and then some of the different interstitial lung diseases as well. So it's a buzzword and it's helpful, but it's not necessarily definitively diagnostic of PAP. As far as the bronchoscopy evaluation, the airway exam itself tends to be unremarkable. When you do obtain a BAL, the effluent has a milky turbid appearance, and that's due to those foamy macrophages. Sometimes there's a monocyte-like alveolar macrophage with an increased number of lymphocytes. And when you stand up that vial, it will have a sediment. It's a little hard to appreciate in this picture, but it tends to layer out, and I think you'll see some of that coming up when I have some pictures of the whole lung lavage. Sorry, this is the PAS staining of the BAL fluid. So again, you see some of the foamy macrophages a little bit more clearly on that right side in the dark blue. Under the microscope, those PAS stainings of the BAL fluid show a granular, acellular, lipoproteinaceous material, also consisting of cells and fat globules. If you do obtain a transbronchial biopsy, you would see the PAS showing positive eosinophilic material within those alveoli with an acellular background. For patients that do undergo a surgical lung biopsy, which is often necessary to obtain the diagnosis in up to 10 to 20% of patients due to non-diagnostic high-res CT or BAL, they would see a similar picture with that eosinophilic material in the acellular background. Here's some pictures of that surgical lung biopsy. So the left side is actually a normal lung tissue, and the right side is PAP. So you can see all those open alveoli are now filled up with this proteinaceous material. So how do you approach a patient that you suspect PAP on? It mainly comes from a high clinical suspicion with some of those characteristic radiographic findings, specifically that bilateral symmetric confluent airspace disease or that crazy paving pattern with ground glass. Typically, your patient will come in with some gradually progressive dyspnea, cough, fever, extending over weeks to months. Their cardiac workup, including a BNP, and for volume status is going to be normal. Their high-res CT shows the classic findings of the patchy and diffuse ground glass opacities, maybe even crazy paving. So if they have one of those underlying hematologic diseases or any of those listed exposures, they might have a reason to have a secondary PAP. If not, you may need to proceed with further workup, including a BAL, maybe a TBBX exam. Based on those microscopic results, it could be suggestive of PAP if you get that milky turbulent fluid, the eosinophilic appearance, and the foamy macrophages. In that case, that's when you would want to check for those serum GM-CSF autoantibodies. If it's inconsistent, those are those 10 to 20% of patients that may need to proceed with a surgical lung biopsy, or else, considering a different differential diagnosis for them. If those antibodies are present, you have gotten your diagnosis of an autoimmune or primary PAP. If they're absent, they do suggest proceeding with serum GM-CSF levels and functions, and then that will lead you more down the route of those congenital genetic disorders that lead to this. If you don't have any abnormal levels or function, they're saying that this is an unclassified case from what I was reading. Okay, so moving on to treatment. The mainstay of treatment tends to be whole lung lavage, or one of them. It was first described by Ramirez Riviera in 1965. It is the standard of therapy. It removes excess surfactant proteins and lipids from the alveolar spaces in order to improve gas exchange. So there was not really any randomized controlled trials available. Median duration of clinical benefit was up to 15 months. This was a study by Seymour that looked at the overall survival from time of diagnosis. And this was, again, the secondary or acquired PAP that was improved if patients received whole lung lavage. Less than 20% of patients followed beyond 3 years remained free of any recurrence. Indications for whole lung lavage include a decline in lung function, a decline in baseline PaO2, worsening opacities on imaging, including chest X-ray or CT. They may have a decline in their diffusion, decline in their worsening symptoms. Mainly it was looking at a limitation in daily activities leading to dyspnea. Patients were more likely to progress if their PaO2 was less than 70 or their A to A gradient greater than 40. The parameters that we look for in a response to whole lung lavage include PaO2. These studies, they're kind of small numbers, but given how rare this disease is with an N of 41, they did see a mean change of about 20, which was significant. They did see a change in the A to A gradient And they also saw an improvement in FEV1 and also in diffusion. So these are some of the parameters that they monitored for continuation of whole lung lavage. Complications of this procedure include hypoxemia. You are lavaging the lung with some fluid, so there is always chance of hypoxemia. You could induce pneumonia as well, leading to sepsis, possibly ARDS, even hydrothorax. There's risk of pneumothorax and pneumomediastinum as well. So those bottles are pictures of that whole lung lavage. I think this clearly demonstrates that sedimentation a little bit better. The R1 is the first set of fluid that was obtained from the right side compared to 17 roughly liters later, where it has cleared up and is less milky with no sediment on the bottom. So that is more what you're seeing in this patient. Just to touch on the GM-CSF therapy, this can actually be delivered either nebulized or subcutaneous. It's indicated for autoimmune PAP where the antibodies are present. A meta-analysis in 2018 evaluated 10 different studies looking at the effects of GM-CSF therapy on these patients. They found that both routes were effective. You just get a little bit more response in these 4 parameters from the inhaled format. So a faster and better response rate, a more significant increase in the PaO2, a bigger change in the alveolar gradient, and then they did see less of a relapse rate, although that was not statistically significant for them. Treatment of the GM-CSF, it's given in a high dose administration, usually like 125 to 150 micrograms twice a day for about a week, and then taking a week off. There's different cycles of that every 2 weeks, and that varies depending on how severe their PAP is and how their response is. And the study, or the meta-analysis concluded that a clinical response was defined as a reduction in the alveolar gradient by about 10 torr at the end of treatment compared to the alveolar diffusion, I should say, by 10 by the end of treatment. And the treatment response rate was really only reported as about 62% of patients across these studies. So this first graph does describe that alveolar arterial oxygen difference. It was measured to determine, or it was used to measure the response to the inhaled GM-CSF in these patients with autoimmune PAP. So it shows that the overall trend for participants receiving inhaled therapy in this dotted line. So they did get a good improvement by about 10 torr in that level with the high dose. They did not see as much improvement once they moved to the lower dose therapy. So after inhalation therapy, they did also notice that cell numbers were increased, GM-CSF antibody concentrations were decreased in BAL samples, and overall less relapse. When they looked at that number of cells in the BAL, here's how they counted that. I believe that the blue line was the higher dose one. So they saw increasing, and then they saw a significant decrease in the autoantibody amount. The only other modality I really saw evaluated was plasmapheresis. As you may think that you could remove some autoantibodies from the plasma with that, helping reduce the amount of surfactant accumulating in that sense. I could only find case reports of this. There was not any actually randomized controlled studies. One of the case reports did show that 10 sessions of 1.5 liter plasma exchanges were performed, and they did get a significant lowering of that serum GM-CSF autoantibody, but there was actually no improvement at all in respiratory symptoms or any of their respiratory impairments on their alveolar gradient, on their PaO2. So most of the patients in those case reports did end up needing whole lung lavage anyways, despite that. So they did not get any benefit, and they deemed that the risks of plasmapheresis were not worth the benefit. I'm going to move on now just to talk about our experience here at Henry Ford with PAP. So there was actually a study done where there's whole lung lavage was performed for PAP here. It's done bilaterally and sequentially, kind of occurring since 1994, a little bit inconsistently, and then more consistently up and through 2013. There was 25 patients included. All of these patients had biopsy-proven PAP. The picture on the right was an example of how this procedure is set up in the operating room. I'm going to talk a little bit about how that setup happens. Initially, there is a single lumen ET tube that the patient's intubated with that's attached to a connector, allowing, or sorry, I should say a dual lumen ET tube that's connected. They do a leak test to see, to insist that there is no saline that is going to leak out around that lumen when they occlude one side to do the lung lavage. So they will actually connect that to the ventilator, and then airway pressures are increased through the ventilator and held at 20, 30, and 40 centimeters of water. And then looking for bubbling of saline in the end of the leak tube that's connected. If they don't see any bubbling, then they repeat it to the other side, and then that's consisting with a negative leak test if there's no bubbles. So they're able to stabilize the patient, wrapping them in several towels and blankets, and taping everything to make sure that none of the elements of the circuit are interrupted during this, and also avoiding any pressure ulcers on the patient's face and skin from the tube. Everything is confirmed bronchoscopically as far as the ET tube placement as well. They usually start with the first lung with the biggest disease burden on imaging for this maneuver. The corresponding arm of the ET tube is closed and remains clamped for 5 minutes to allow the lung to degas. And then they begin the lavage once they've assured that the system is air-free, meaning the circuit system. They will give multiple liter bags of normal saline that's been warmed to 37 degrees Celsius, hanging above the heart, and I believe given with gravity. So in total, there was 2 procedures per patient. That's how they got to, I believe, 25. So 13 patients were involved in this study. Most were male, 61%. About 70% were Caucasian. Open lung biopsy was performed in 8 of those patients to diagnose PAP. The others were also biopsy proven from TBBX. The time from diagnosis to their first session ranged from less than 1 year up to 4 years. And 2 patients were treated while they were actually inpatient before that procedure. The time for this procedure, since the picture before alluded to needing 1 to 17 suction bottles, so it can take a little over 2 hours, almost up to 4 hours, I think, if I'm doing the math correct, 5 hours, with a mean time of about 200 minutes. Takes a lot of normal saline. Most patients averaged about 31 liters. It ranges anywhere from 6 liters up to 30 liters per lung. And the final fluid balance at the end of the procedure, meaning what that they were instilling versus what was actually kind of reobtained out, did sometimes go anywhere from 0 up to 2.5 liters. So actually, I don't know if I say this later, but the procedure is continued until the physician evaluates that appearance of the fluid and seeing that it is clearing up. I think you actually mentioned that later. There is different discussion about using optical density to monitor the fluid quality to determine end of procedure. So the standard treatment with improvement in symptoms, function, and radiographs was obtained in this study for patients undergoing whole lung lavage. For these patients, most common indications of this were the decline in lung function. They either had a worsening PaO2 or worsening SpO2, worsening changes on their chest imaging, and then went ahead with the procedure. Again, this is just a reminder, those are the parameters that we're typically looking for response to based on the previous literature. And again, just the termination of the procedure was determined by visual assessment of the color and sediment done by an experienced physician. A physician named Bonella did use optical density monitoring to quantify the protein content of the return fluid. And there was not really any data comparing the two. They found that the expert physician's evaluation was adequate. Completion of the procedure. So about 63% of cases were able to be weaned from the ventilator and discharged home the same day. After the lung lavage was completed, they would typically remain on the ventilator for about 4 hours for adequate oxygenation prior to extubation. There were a few patients that did get admitted for observation, and I believe one had complication with pneumonia. By the end of the procedure, their oxygen saturation had actually improved by about 5 points, 5 percentage points at the termination of it. And all the subjects did have a subjective improvement in their dyspnea. Most of the procedures related to that positioning, and then once they begin, it relatively shortens the time of it. So just to talk a little bit more about those complications, the hypoxemia that occurs is believed to be transient. It occurs during emptying of the lung rather than when the saline is being infused, because they believe that the lavaged lung releases, or the lavage releases compression of the capillary bed, and that causes shunting. And some of that fluid may be absorbed, leading to pulmonary edema. Only 2 of those patients did require staying on the ventilator for more than that standard 4 hours post-procedure during this study. They do believe that pneumothorax occurs from excess alveolar distension during it. None of the patients in this study had that occur from my understanding. So in summary, PAP is due to that accumulation of the amorphous PAP positive lipoproteinaceous material in those distal air spaces. There's primary versus secondary, also congenital. It's due to that, the primary autoimmune components due to the neutralizing autoantibodies that stop that effect of GM-CSF on the maturation of alveolar macrophages. It has a very insidious onset. Most common symptoms are dyspnea and cough. On radiograph and on high-res CT, you will typically see that geographic distribution of ground glass opacities, although it can be nodular or unilateral in some cases. Treatment involves the standard of care with whole lung lavage, although there are options for GM-CSF as well. And these are my references. And my dog was pretty sad when I went to work today, so that's Jack.
Oh, that's a beautiful picture of your dog.
Oh, thanks.
Sad though. Well, thank you very much, Katie. Is there any questions? Let's see, I have one here. So one of the questions is, a usual BAL can elicit an inflammatory response and hence fever post-BAL. With this high amount of lavage volume, is there more chance of triggering inflammatory cascade? Well, the answer is yes. It definitely is a possibility when you talk about the whole lung lavage. However, I have to say, if there is one, it's very transient. We, at least in the study that we did here and the case series that we've had, we didn't really see that much of it. But rather improving on the oxygenation on all the patients, the time, what usually happens in most institutions is after a whole lung lavage, these patients go and get admitted to the hospital for 1 or 2 days. They usually get weaned from the ventilator again, within a day or so. What we have seen in our experience is that these patients not necessarily need to be admitted to the hospital. We kept a lot of these patients, actually most of these patients, on the recovery part, because this is done in the operating room, this procedure. So we keep them in the recovery. We extubate them. As soon as they're extubated, they just they get watched. They get watched for an hour or 2, and then they go home. So that's our experience. Sometimes what we do is we help them a little bit with diuresis. We have noticed that sometimes in patients for the amount of fluid that was instilled on the alveoli, that hypoxia, even though it gets better, it doesn't get that better as we wish they were sometimes. And then with diuresis, they tend to improve better. But Yes, it's a good question. I mean, it could trigger an inflammatory cascade, but again, in our experience, we have not seen that. Anything else you want to add on there, Katie?
No, I think that that's what I was seeing in the literature as well. So
Mhm.
I think that's all.
And then another question that was earlier is just to clarify, that the diagnosis of PAP is done um, um, by bronchoscopy, either a BAL, transbronchial biopsies, or open lung biopsies. You don't need to do open lung biopsies in everybody. Actually, can you show that, Katie? Can you go back to that slide where you have that?
Like that diaphragm or the
Yes, the diagram with there.
yeah.
So see, you don't really need to do an open lung biopsy in every single patient. The clinical suspicion can be high just by you looking at all the radiologic characteristics of these patients. And if you suspect, you highly suspect this, then you need to have some sort of confirmation, some sort of pathologic confirmation or cytologic confirmation. Sometimes BAL is more than enough. You do the PAS stain, and then you're able to make a diagnosis. TBBX is not needed all the times. An open lung biopsy is less needed nowadays. But then after you do that, then is when you start now for checking on what the GM-CSF antibodies will do, whether there was a decrease on the GM-CSF levels, and if there's any antibodies, and that's going to guide pretty much your therapy mainly. So it's not necessarily, and then the classification, of course, and hence your therapy. So you don't do GM-CSF when you suspect somebody has PAP. You have to confirm that is already PAP before you start ordering all this testing. Besides, very difficult test to perform. It's not done on, it's only done in like 2 or 3 institutions here at the United States. The institution we send it to is the Cincinnati, University of Cincinnati. They actually run it. And I think it's Mayo Clinic also that runs, and that's it. But yes, that's how we usually do it. Anything you want to comment on that, Katie?
No, I don't think so. I think that that confirms most of the cases were diagnosed by bronchoscopy. I think it just happened that in the Henry Ford study, 8 of those 13 did, I think, have open lung. So it's not the most common way to find this diagnosis. It's mainly your clinical experience and then bronchoscopy. You shouldn't be ordering the antibodies as your very first test.
Right. And then in terms of the techniques for whole lung lavage, there has been multiple techniques or different techniques out there that have been used. There were even techniques in which they use partial lavages, like lobar lavages, in which they would do only like lavage in 1 lobe or 2 lobes, etc. You also have to consider when you do this kind of procedure, what is the condition of the patient. These patients are hypoxic in general. Otherwise, you wouldn't be doing this. Just because you have a patient with PAP and there's no hypoxia, it doesn't have symptoms, you don't have to do a lavage. So just keep that in mind. This is the lavage is not necessarily a permanent treatment for this kind of patients. Um, uh, so um, uh, so once you do, in order to decide a lavage, patients need to be hypoxic, need to have some symptoms, otherwise you don't do it. But then again, if the patient is very hypoxic on the ventilator, we've done it also. And in those cases, we're a little bit more conservative. We've done only 1 lung first, and then the patient rests. Once the hypoxia gets better, then do the 2nd lung, on a different day. These patients show is a very um, uh, um, the response is very fast and is really something that you don't see that often. Is the patient goes very symptomatic to the procedure and hypoxic, and then once the procedure is done, within a few hours they're just again on room air, and it's really it really makes you feel good with these kind of procedures. But any other questions? Hold on. you have access to talk. So if you want to ask any questions, please go ahead. Okay. Okay, Katie, any last thing?
No, I don't think so.
Okay, good. Thank you very much. It was a great presentation. Thank you very much for putting this together.
Thank you.
Okay, thanks. Okay, so I'm just going to ask you for just 1 minute. Give me a couple of minutes to put everything together for the next talk, okay? Okay, so it's gonna be 1 minute before we start with the next conference, which is gonna be the Journal Club by Hala. It's also regarding pulmonary alveolar proteinosis. Just a couple of things for the ones who didn't hear. There's going to be a guest lecturer for next Friday from University of Michigan. Dr. Hidrani, he's going to talk us about a discharge criteria from the ICU, and it's going to focus mainly on COVID patients. So it's going to be a great lecture. So please attend. This is going to be next Friday, May the 8th at 12 noon. So I would like everybody to be there present. And again, this is going to go over to all the ICUs, surgical ICU, etc., as well as internal medicine residents will be present there too. Okay, so let's see. Okay, Hala, you're able to share your screen?
Can you see my screen?
Yes. Hold on a second. Yeah. So we're going to leave now Hala. She's going to talk about a very interesting article. It's not one of the most recent ones, but I believe this is probably one that contains most of the information of what we actually know about PAP nowadays. So I'm gonna leave you with Hala now. Go ahead, Hala. Thank you.
Hello, everyone. I'm presenting the journal club for today, and the paper that I'm going to be talking about, it's called Assessment and Management of Pulmonary Alveolar Proteinosis in a Reference Center, that was published by Campo et al. In Orphanet Journal of Rare Diseases in 2013. So just quickly, if you kind of like already forgot a little bit of what Katie said, just a quick refresher as a background about pulmonary alveolar proteinosis, rare disease. It's a diffuse lung disease, accumulation of lipoproteinaceous material in the alveoli and alveolar macrophages due to abnormal surfactant homeostasis. The alveolar macrophage maturation is typically caused by inadequate granulocyte macrophage colony stimulating factor signaling, which is crucial for the development of the full range of alveolar macrophage metabolic and immune functions. The consequence of PAP is impairment of gas exchange and hypoxia. Pathogenesis, as Katie said, there are like several types. The most predominant one is autoimmune PAP, idiopathic PAP, which is you have antibodies to GM-CSF leading to the deficiency of bioavailable GM-CSF. There's congenital PAP, which is a genetic defect in the receptors alpha or beta change in the GM-CSF. Leads to impaired macrophage maturation. Usually that presents in the neonates. It kind of like develops into lung fibrosis. There's secondary PAP, abnormal alveolar macrophage function because of several hematological or environmental factors, namely MDS, hematologic malignancies, lymphomas, leukemias, and dust. This is a quick picture that shows like this is the normal alveoli. This is the like the abnormality that happens with the pulmonary alveolar proteinosis. The diagnosis, usually symptoms, you have clinical suspicion, you have crazy paving on the high resolution CT scan, you have a characteristic appearance of the BAL, milky fluid, and then like you do biopsy, transbronchial or open surgical, and like this is usually what you find. Now the treatment, usually for patients with moderate to severe disease, whole lung lavage is still the first line treatment of choice. There is supplemental GM-CSF, details about indication choices. It's still unclear, it still like needs more. It's usually reserved for those people who do not respond to whole lung lavage. There are other investigational therapies like rituximab, plasmapheresis, lung transplantations that have been described, but they're not the cornerstone of therapy as whole lung lavage. So just to give a quick context about what I'm going to be talking about next. So there are a lot of, not a lot of, it's a very rare disease. There are several pulmonologists who studied PAP patients, and they were cohort. They reported their findings on cohorts of patients. So I'm just going to talk about those quickly just to give context to what I'm going to talk about next. So Seymour in 2002 from Mayo Clinic, what he did is reviewed all the PAP cases available in the literature, and he included 34 patients. He followed at the Mayo Clinic. That was a total of 410 cases. And then in Japan, Inu in 2008 followed 248 cases. Zhu 2009 in China followed 241 cases. There's Bonella in 2011, and he followed 70 PAP patients at a single center in Germany. And now we have our study by Campo et al. They followed patients in a single center in Italy. So the design for this study, it was a single center in Italy. Patients were prospectively enrolled in the cohort from 1989 until 2011. They ran a retrospective analysis in this cohort after they collected these patients. The number of these patients were 81 patients, including all types of PAP. And I wouldn't say inclusion criteria, but it's basically like everybody who's eligible to enter was like basically a PAP patient, and they made the diagnosis presence of crazy paving pattern on high resolution CT, or the presence of macroscopic milky fluid on BAL, plus minus the presence of amorphous eosinophilic PAS positive material, as well as lipid-laden macrophages on BAL analysis. So this is how they kind of like made their diagnosis. The minute they diagnosed them, they enrolled them in this cohort of these patients. The aims, what they really wanted to do, first to describe the clinical characteristics of the disease at presentation in their series of patients, the 81 patients. And then they wanted to analyze some of the baseline functional and biochemical parameters, especially when it comes to long-term follow-up, especially when they needed whole lung lavage. So let's talk a little bit about the study patients. So basically, the most important thing that we infer from this table is that the majority of them were idiopathic autoimmune, 90% of them. And this is what they ended up like running the retrospective analysis on, just like to keep them homogeneous. So they kind of like didn't look into the secondary PAP or like the hereditary PAP. So mainly 73 patients with idiopathic or autoimmune PAP. So again, like from this table, majority of patients were like middle-aged, 40s to 50s. 2/3 were men. It's actually the ratio 2-to-1 male to female ratio. 2/3 were smokers, either previous or current smokers, with 1/3 being non-smoker. And they had 36% with previous exposures. The majority of these exposures were inorganic exposures like silica, cement, and so forth. So symptoms of enrollment, the majority of these patients had either dyspnea or cough, and like plus minus or both of them on presentation. The majority were 95% were symptomatic. There are like a few of them who had fevers, sputum production, maybe some were asymptomatic, but the majority had dyspnea and cough on presentation. The diagnostic procedures, majority got a high resolution CT scan, then biopsy and BAL. GM antibodies were introduced in 2004. However, the interesting thing that they noted is that it didn't reduce the need for biopsy. Like prior to the introduction of the antibodies, they performed biopsy on 60% of the patient, and that decreased to around like 52% after the introduction of the antibodies. They also like ran the lung functions on these patients. What stands out is that they had like impairment in DLCO and gas diffusion and elevated AA gradient. And the interesting thing is that they ran tumor markers on these patients. The majority of them, all of them pretty much, or the majority of them, like for whoever the results were available, they had elevations above baselines, elevations in LDH, neuron-specific enolase, cancer embryonic antigen, and cytokeratin fraction as well. Okay, hope you can hear me better now. An interesting thing is called disease severity score. It's based on the presence of symptoms and the degree of reduction in PaO2. It was suggested as an index of the severity of the PAP, and it was divided into 5 grades, with 5 being like the worst, obviously. 2/3 of the patient they enrolled, they had in their cohort were DSS 2 or 3. Okay. So the indication for the whole lung lavage in this cohort at their institution was persistent or progressive respiratory failure, drop by 5 or more percentage points of O2 saturation on treadmill exercise, and they used the modified Bruce protocol determined by pulse oximetry. So those are the patients that they put up for whole lung lavage. Now, from the patients that underwent the whole lung lavage, so you would notice 29%, 1/3 of the patient didn't require any whole lung lavage. 31% of the patients required 1 whole lung lavage. So to put it into perspective, like 2/3 of the patients required at least 1 whole lung lavage to kind of like improve symptoms, with the majority requiring only 1, and maybe like smaller numbers for those requiring more than 1, 2 or more. The interval between 2 consecutive whole lung lavages were around 15 months, like a year, 2 years, something like that. So the interesting thing that they did afterwards is that they looked at the baseline pulmonary function data between the patients who were never lavaged and those who were lavaged once or more. This is a very busy table, probably it will induce a STEMI in you guys, but what we really need to look at is first the tumor markers, cancer embryonic antigen, the cytokeratin fraction, and LDH. Those who didn't require whole lung lavage had lower values than those requiring more than one or more whole lung lavage. And looking at the statistically significant lung functions, those who didn't require whole lung lavage had higher forced vital capacity in comparison to those who required lavage or one lavage or more. And the DLCO was higher in comparison to those who didn't require any lavage in comparison to those who required one lavage or more. What they did next, which was interesting, is that they compared the published cohort that we initially talked about at around like slide 8 with their own cohorts. Again, Asia diagnosis, it's 50s, 40s, 40s, 50s, male to it's mainly male predominant disease. Most of the patients in those like recorded were primary PAP. Some were like smoker, majority were smokers as well. The interesting thing that they noted is the whole lung lavage. It was performed, certain institutions, as you'll see, like 54% of the patients, 59% of the patients, and 54 here got at least one whole lung lavage in comparison to Bonella in 2010. That like 90% of his patients required whole lung lavage. And we'll talk about the implication for that later. So to talk about strengths and weaknesses of this study, so the strength is a large sample size, 81, which is significant for a very rare disease. The weakness is retrospective analysis. There were missing data on some patients, which they kind of like made up for with the high, like with the large sample size for this rare disease. What they found was functional, meaning DLCO and FVC, and biochemical LDH and tumor markers parameters were investigated in relation to the need for repeat whole lung lavage, which none of the previous studies did. However, what they like the weakness of the study is that none of these markers was able to discriminate the PAP patients lavaged once from those requiring more than one lavage. Another strength is that the majority of the patient studies received whole lung lavage when clinically indicated, pretty much similar to other centers. However, there was no standardization between these centers for whole lung lavage, especially in exercise-induced respiratory failure. Like as we said earlier, like in one study, 90% of the patients received whole lung lavage in comparison to 50-60% in other studies. And like there's no clear-cut like criteria to kind of like, choose and pick who will undergo this procedure. Another nice thing about the study is that they compare their own cohort to other published data from previous cohorts to kind of like put things into perspective and see like how their center was performing in comparison to other places. So in terms of conclusions, PAP is definitely a rare disease, more male prevalence. Again, majority of the studies 2-to-1, 2/3 were male. Mean ages 40s to 50s. Majority of cases are primary or autoimmune. The best predictors for the need to perform whole lung lavage are biomarkers, CAA, LDH, and so forth, and the functional lung parameters, diffusing capacity, and FVC. Disease severity score was not significantly different between not lavaged and lavaged PAP patients. Also, the PaO2 and the change in AA gradient did not significantly differ. No baseline parameter was able to discriminate PAP patients requiring a single lavage from those eventually requiring more than one. However, like those parameters were good predictors if you were to perform lavage versus not to perform lavage. However, it couldn't really tell you if you needed to perform more than one, what patient would need to have like more than one whole lung lavage. and it remains the standard of care, although no indication at that time in 2013 when this study was published, there were no indications, good indication standardization for this, like for patient selection for this procedure, and guidelines for that as well were lacking. Okay, thank you very much, everyone. Any thoughts, comments, questions?
Well, thank you very much, Hala. That was very interesting. So everybody's able to participate and ask questions. Any questions from the audience? So one of the things that I, you know, about the study and about PAP in general, we kind of talk about it, but it's in regards of the real therapy, right? And so as Katie already mentioned, the real treatment is actually is given in two parts. One is try to improve the symptoms and immediate relief of symptoms, as well as the hypoxemia that when the patients develop that. And for that will be the whole on lavage. Again, that doesn't do much to permanently cure the patient from PAP. So and the second part of the treatment comes to, okay, so differentiating whether this is primary versus secondary. And then if it's a secondary, then you need to treat or manage what the secondary cause of it is. If it's an infection, myocardial, for example, then you have to treat the infection. If it's a malignancy, then you have to manage or treat the malignancy. And if it's a primary or congenital, then what you're gonna have to do is, if the patient does have a GM-CSF levels that are low, then they will need some sort of a treatment for that, meaning replacement for it, for example. So it has to do a lot. It has to do a lot with that. So don't take it as the whole on lavage to be the treatment or the entire treatment for this condition. Now, on the other hand, we have seen a lot of patients that they have congenital or they have a primary PAP, and for some reason, you know, the disease kind of vanished after an average has been like between 3 or 5 whole on lavages or procedures in general. Nobody really knows. Nobody has followed these patients long enough to say whether this will recur or not. But that's what we have encountered before, and then that's what the studies also encounter in terms of 3 or 5, between 3 and 5 lavages, and patients get better. It doesn't mean that the lavage did something to it. I just believe that whatever was causing the issue just kind of vanished, and then now the patient got better. Any comments about that, Hala?
No, not really. I agree with you, Dr. Diaz. Again, like as you said, this is like the significant thing about the studies that they followed up their patients for 2 decades almost, which was really significant. But still, like there's so much to do and to look for in these patients. Yep.
So now the other thing is there's a question about the PFTs. How often do you do them after the whole on lavage? Really, it will depend. We actually, the way that we manage them here in our protocol, we bring them every 3 months initially. Actually, a month after, which is 30 days after the procedure, we do PFTs, and then 3 and 6 months after that, and then continue. Again, it will depend. The patients already know when things have started to get worse for them. They start having the symptoms. Doing PFTs, remember, overall the DLCO can predict whether the patient may or may not have a, or will need, I would say, another whole on lavage. But again, there is no clear criteria, as Hal already mentioned, and Katie too, in terms of when to do the whole on lavage on these patients. There has to be a balance in between the symptoms that the patients have as well as hypoxia the patients have. So there's no really clear cut. Some people use if there is a decreased in oxygenation or O2 saturations below 5%, then oh, I'm sorry, for 5% or above, then this is when this is an indication. But again, it's always a combination of the symptoms of the patient, how much distress does the patient have, how much hypoxia does the patient have, and then also changes on the PFTs. Remember that these patients may not necessarily worsen because of PAP all the time. They also sometimes are associated with other conditions. We have patients who have had a history of, for example, heart failure, liver conditions that can make them fluid overload. They can look exactly the same. Remember a couple of patients, one with heart failure, one with liver disease, that presented that way. They were diagnosed with PAP biopsies, and they pretty much get fluid overload from time to time, and this was related to either the heart or the liver. So you still have to assess and then not necessarily blame it to PAP in general, right? So just keep that in mind. Any other questions? Okay. So well, thank you very much, Hala. I just wanted, it was a great presentation. Thank you. So I just wanted to see whether you guys have any questions. I was like we have been talking over the last few weeks. Is there any things? I mean, not with the fellows mainly, but now that things are kind of slowing down to work here at the hospital, that's actually great. But anything that you guys may want to share, how things doing at home or where you're working. Today was switch day, so it seemed that everything was sort of like smooth in general. You guys can talk, by the way. So who is doing West Bloomfield?
I just finished yesterday.
Oh, how was that, Maria?
It was good. It slowed down a little bit this week.
Mm-hmm.
No second wave, but triage got a little bit better.
Mm-hmm.
Still very sick patients. They said, I mean, I only did 1 month there.
Right.
They said they never experienced anything like that before. It was very busy, but I don't know. I have nothing to compare with. It was okay. I hope Asif is going to start his rotation today on a better note than I did.
Okay, that's good. That's good. So yeah, that was the issue. I think their surge was a little later compared to us here. But yeah, when you see the numbers there, they started to get kind of worse after we already were coming down. But yeah, I'm glad that it actually worked well. And I know that, are you back now at home, or because I know that you have rented a place, you were staying around.
I rented Airbnb, then I stayed in Extended Stay America that Henry Ford provided me a location for a week. I'm back home. I'm really hoping to be able to go back to Neuro ICU, but I've heard from Nicole that we're trying to negotiate with the leadership to see if we can go back at some point, hopefully next week. I don't know.
Oh, I see. Okay. That's a possibility. I see there as if he's having issues with the mic. He said that things are slowing down. He's right now at West Bloomfield, so yeah. Okay, I'm glad to hear that then. That's I think the whole state is seeing that. Hopefully it doesn't, as you said, there's not a second wave soon. We're hoping that it doesn't happen, although how things are going, it seems that it may be. Any other issues anywhere else? Any other rotations? They're picking up, I know, in bronchoscopy. Now we're pretty much not almost, but I would say we're probably 60% of the cases that we're doing are happening in bronchoscopy. Some of the ICU, as you know, services are disappearing. One thing is the I6 service disappeared as of yesterday. So there's no longer I6 ICU, either for fellows or for staff. I don't know how that's going to be in the future. Again, we just have to play by ear. There's in the surgical ICU, seems like there's also some of the patients are being just, all the patients in COVID are just being put under one team instead of two teams, which is also good. So let's see here.
Hey everybody, it's Geneva. Can you hear me?
Oh, hi Geneva. Yes, we can hear you.
I was just wondering, what are you guys doing to kind of, you know, keep yourselves well? Are you doing anything outside of work to kind of stay sort of mentally and physically feeling okay?
Do you see that, Geneva? I don't know. Are you guys able to speak or?
I've just been eating lots of Reese's and I'm going to try to get back into running a little bit.
Yeah, you're my running inspiration, Daniel. I'm like, if you're not doing it, I don't feel bad that I'm not. So
I keep hurting myself, so I think I need to stop.
yeah, take a break. Walk instead.
Yes, indeed.
There's a question about the research on immunoglobulins. I heard about that. I don't know how it's actually happening. Do you know anything about that, Geneva?
Immunoglobulins, I don't know that I've heard. Or are they talking about convalescent plasma? Because my study for convalescent plasma, I hope it will be starting on Monday. And I'm actually going to be looking for some assistance from some of you guys. I'm going to send an email a little bit later to see what your interest is in kind of participating in this project. So more to come on that.
So there's one, it says testing asymptomatic healthcare workers. Do you know anything about that, Geneva, or is that, I don't see that happening at all, but I don't know if you have any other.
That's currently not happening within our system, although there's a movement towards that. There is some testing locally for healthcare workers, first line responders, if you will, irrespective of symptoms. I think the only testing center that I know of off the top of my head is probably the Michigan State Fair site, which does it there. You know, specifically looking at first responders. But let me see if I can find some more information right now, actually.
Any other questions you guys have? Something you want to share? How many movies have you seen or watched on Netflix? Are you doing the Netflix, what is that, Netflix share, or how is that called? Netflix buddy or something, that you're allowed to see or watch movies with somebody else at the same time? Okay.
I know, did you talk about graduation at all, Javier? Or?
Well, not really, except as I told you from the last Friday, there was a question about it. I mean, we know there's going to be, I mean, something is going to happen on that day, the day that was already, we talked about on the 12th, that was already scheduled. We don't know exactly, depending on the regulations and limitations from the state, what we'll be able to do. But no, I mean, go ahead, feel free to say more than that.
Yeah, well, currently what we're trying to do is make a swift adjustment given the current guidelines by the health system that is continued to minimize large gatherings at least until May 31st. Graduation, you know, has been scheduled for June 12th, and the plan is to still have it on that day. But certainly our plans for our typical very large graduation ceremony with 100 people on average is likely not going to happen. So we're going to pivot to sort of a different graduation. And we're trying to iron out those details right now with help from GME as well. So graduation still will happen. It will still be on June 12th, but it will be much smaller. And so some of our participants will probably have to be remote to see the graduation and to help celebrate our graduates. I think, you know, it's very important for me that our third year class really have a great graduation despite all of the changes and the pivots that we've had to make. That class has been through a lot in their 3 years of training. And so they really need a huge send off to, you know, to show our appreciation for them and their sort of tenacity through all of the changes, not only with COVID, but all of the things that they've experienced over these past 3 years. So we want to make sure we do it up big and we do it up well, even though we have to maybe do it up a little bit differently. So there'll be more info coming as that kind of gets ironed out.
Yeah. Good. Any other questions you guys have? Anything else you want to share, Geneva?
I don't know if you're kind of leading me down one pathway, but one thing I do want to share, I don't know about you guys, but I was really disappointed with the first responders or frontline heroes awards that came out yesterday. I was not happy about that, and I let GME know about that. So me and the APDs have decided to take it in our own hands, and we're going to have our own frontline heroes award for you guys, because you all have been frontline from the very beginning. You continue to be frontline. You've been working above and beyond in every capacity imaginable, and you deserve acknowledgement and recognition. So there's going to be some good stuff in store for you. I can't give you all the hints just yet, but there's going to be some fun stuff involved for you, just again for us to say thanks to all of you, to recognize you, and to show you some much deserved appreciation. You've been fantastic. I personally am very proud of you and couldn't ask for a better team to lead. So thanks to each and every one of you.
Yeah, that's actually great. That was a great idea from Dr. Tatum. It's gonna be, I know that we were very disappointed in general for what happened, but everybody is a hero for us. That's how we feel. Okay, so I think that will be it then for today. That was a short 2 hours, or hour and a half. Please remember, as I told you already, for next Friday with our guest speaker, it's going to be at 12 noon, from 12 to 1, and then we'll have a lecture by Nor after that. So everybody have a good weekend, good days, and we'll keep in touch. Thank you very much for attending.